Yeah.
Okay. So at the outset, I would like to thank the organizers for giving me this opportunity to be amongst you, and that too after a tiring 1.5 months, which was pathetic for almost all of us. So the topic which has been given to me is albuminuria, pitfalls in diagnosis and prognosis. So I begin my slide with three very relevant questions. Whenever somebody is diagnosed as having albuminuria, so the three challenges or three clinical questions are that do I have kidney disease? What are my risk of progression to chronic kidney disease or end stage renal disease? My risk of cardiovascular or all cause mortality. These are the three relevant clinical questions which we encounter. So let's begin by history. In 1750, Cotugno, Italian physician, first coined the term albuminuria from a patient with nephrosis, and erroneously, he said it is due to dropsy. Then it was the brilliant scientist Richard Bright who placed kidney at the center of the picture as primary seat of disease. He linked albuminuria to disorder of the kidneys. And it was this gentleman, Herman Senator, who said that albumin may be found in subjects without primary kidney disease, that it can be seen in normal individuals as well. We begin with albumin homeostasis. It is a small negatively charged protein synthesized mainly by liver, contributing around 10% of the protein production. It makes up to 75% of the normal plasma colloid oncotic pressure and 50% of plasma protein content. Production is highly regulated process, modulated by various physiological and pathological conditions. If we look at the metabolism, breakdown occurs in most organs of the body, which is mainly in muscle and skin. Renal tubular cells reabsorb the majority of the albumin that is filtered by glomeruli. Some say that tubular cells degrade albumin via lysosomal proteolysis. Well, other challenge this theory, saying that albumin is protected from lysosomal degradation and recycled intact by tubular transcytosis. This is the classical glomerular filtration barrier, where you can see this is the glycocalyx. This is the capillary endothelium. This is the glomerular basement membrane. These are the podocyte, and you can see the slit spaces or slit diaphragm here. So multiple hypotheses have been postulated how this is achieved. Size of the endothelial filtration pore. So you can say that it has got a size selectivity. There is a spherical configuration, and there is also electric charge theory. So a universally accepted theory has not yet been agreed upon, like many other theories in medical science. So basically, it is constant dynamic interaction between the podocyte, glomerular basement membrane, and the endothelial cell. Let's begin by the definition of proteinuria, which is anything which is abnormal excretion of protein by the kidney, including any or all protein which is excreted. Normal protein excretion is around 150 milligram per day. And albuminuria, that is macroalbuminuria, is 300 milligram per day, and microalbuminuria more than 30 milligram per day. If we look at the various reference values, here are the reference values. One important thing I would like to discuss here is the change in KDIGO terminology, where they have changed the term, where they say normal is normal to mildly increased albuminuria, that is category 1. Microalbuminuria is moderately increased proteinuria, albuminuria, that is category A2. And albuminuria or clinical proteinuria, where you have severely increased albuminuria, that is category A3. And then you have nephrotic range proteinuria, which is more than 3.5 gram per day per 1.73 meter square. If we look at the estimation methods of albuminuria assessments are semi-quantitative calorimetric assays. The most famous one is dipstick, and you have quantitative immunochemistry based assays, which is immunoturbidimetry, nephelometry, and other methods. When what we see here is the most commonly, which we initially use as dipstick, and this roughly correlates with quantification as given in this small table. The collection of the urine sample is very important. Preferable measure same day, if not then can be stored at 4 degrees centigrade. They are also stable for at least 2 weeks at 4 degrees centigrade and 5 months at minus 70 degree centigrade, but ideally it should not be frozen. Traditionally, detection of albuminuria starts with the dipstick test. It is used in some countries for the screening program. test is semi-quantitative and insensitive. And currently, urine albumin is predominantly measured in diagnostic lab using immunoturbidimetric assays. Now, you can also have transient elevation of albumin excretion, or where you can have falsely elevated albumin without a known kidney disease. So that can occur in fever, infection, urinary tract infection, heavy exercise in the last 12 to 24 hours, heart failure, poor glycemic control, elevated blood pressure, hyperlipidemia, or sometimes in normal menstruation. If we look at urine ACR and PCR, so which one to choose? The first controversy is whether urinary albumin creatinine ratio or urinary protein creatinine ratio. So ACR, basically albumin creatinine ratio, conducted with standardized technology and antibodies directed against albumin. So it is more standardized, and PCR test is usually done with pH indicator dyes. ACR is considered the method of choice by guidelines, but fragmented albumin by tubular processing may not be detected by the normally commercially available antibodies. And indicator dye-based protein measurements will quantify these missed albumin fragments. So PCR can detect other non-albumin proteins and higher molecular weight protein as well. So some adequate PCR superior to ACR for detection of albuminuria. But PCR cannot discriminate among the various urinary proteins. Therefore, ACR is clearly superior to PCR even in some tubular disorder. And morning ACR is preferred to reduce the variability of urine albumin excretion. But PCR is preferred in paraproteinemia. Albumin creatinine ratio also depends on the muscle mass because you have a creatinine fraction here. So ACR in females, elderly, and with muscle wasting overestimate true albumin excretion rate. So this was an article where they compared association of UPCR versus ACR with complication of CKD. And what they found that there remains a discord among national and international guidelines, with some advocating ACR to PCR and others recommending retaining protein creatinine ratio. Our study supports the argument that measurement of PCR should not be completely abandoned in clinical practice. So wherever you have a facility, whatever facility you have, if they are measuring PCR, go ahead with that. Now comes time sample versus spot sample, the biggest controversy. So time sample or protein excretion rate, it is difficult to collect every drop of urine, and this is the biggest problem. And one thing more, commonly when we order 24 hours urine protein, we never simultaneously order 24 hours urine creatinine. So until unless you do that, we are not sure about the adequacy of collection. So creatinine excretion rate calculation is also flawed, but then it gives you some idea of the adequacy of collection. As creatinine production vary from day to day related to differences in diet and muscle metabolism, you have improved equations which are based on sex, race, age, and weight, which are available, but they do not adjust for variation in creatinine production. Protein excretion rate follows an hour-to-hour circadian rhythm and also influenced by diet, posture, and exercise. Day-to-day variation in protein excretion rate and creatinine excretion rate will affect their reproducibility. So difference in PER between consecutive urine collections errors are collection errors or biological variations we do not exactly know. When we think about spot urine, it is good because it is an easy way of doing it, but it only provides a snapshot of the day. So there is an hour-to-hour variation in urine protein and creatinine excretion, and they may not match the PCR or ACR if it had been determined based on 24 hours collection. And which is worse is a poorly collected time PER. So which is worse. So ideally a poorly collected time PCR in which the value may change from a day to day, even if collected properly, or relying on a spot urine sample that gives only a snapshot of the day. So there remains a controversy. So this was a beautiful AJKT block, which was published in American Journal of Kidney Disease by a famous nephrologist, Robert Rodby, who said timed urine collection for albumin and protein. The king is dead. So he said, now it is a demise of timed collection and long live the king. That means long live ACR. So what was his argument? Let's see these three clinical scenarios. There is a 50 kg man, 75 kg or 100 kg man. Creatinine excretion rate, we assume it to be 1 gram because that's how you calculate ACR. Now, ideally, looking at the mass, the creatinine excretion gram per day would be 1, 1.5, and 2. And protein excretion rate per day would be 6 gram, 9 gram, and 12 gram. But if you see spot PCR, it remains 6. So protein excretion rate, usually we do not adjust it to body size. So ideally, 24 hours urine protein excretion should always be, corrected to the body surface area. But then there are relevant clinical questions. Does a 100 kg patient really have 2 times worse glomerular disease? It seems logical, but remains speculative. Would require confirmation and a large site population with long-term follow-up. So for all here, a time spot collection remains an attractive option as it automatically adjusts for body size through relative to creatine excretion, which is a surrogate for body size. So trends are basically more important. Trends in your albuminuria is more important and give credence to individual values, no matter how flawed the individual values may be. So trends guide us clinically. Now, the relevant question which begins first is that, do I have kidney disease? Then there are a lot of data which are published in the literature, which says that if you have kidney disease, there is definitely a high risk that you are having a kidney disease and a high risk of progression. So is albumin creatinine or measuring albuminuria, is it ideal screening tool? So ideal screening tool should qualify this Wilson-Jugner criteria, and albuminuria, to our delight, almost fits in all this. So that is why the recommendation says that high-risk patients, whether it is KDIGO or ADA or NICE, that says that whenever you are a high-risk patient, you should always be screened for albuminuria and checked at regular intervals. Now, let's say once I have been detected albuminuria, what are my risk of progression to chronic kidney disease or end-stage renal disease, and my risk of cardiovascular and all-cause mortality? Well, there are a lot of data which have been published which says that albuminuria is a marker for kidney disease in apparently healthy individuals, as well in patients with different comorbidities such as diabetes, hypertension, and obesity. It may precede the appearance of type 2 diabetes mellitus being present in insulin resistance syndrome. And here you can see, as proteinuria worsens, there is chances of mean decline in EGFR. Well, this risk of production of kidney disease, famous Framingham study, which also suggested that you have an increased overall mortality and cardiovascular mortality when you have more proteinuria. Similarly, here you can see the more proteinuria you have, the more chances of worsening of the diabetes. Albuminuria, proteinuria, and dipsticks. This was a publication recently in 2021 where they have formulated a kidney failure risk equation where they calculate the kidney failure risk in an individual, and albuminuria is an important component of this kidney failure risk equation. Similarly, there is also an association between EGFR rate decline and albuminuria with mortality in general population cohorts, which this was published in Lancet, and it clearly says that EGFR and albuminuria were associated with all-cause mortality and cardiovascular mortality, independent of each other and traditional cardiovascular risk factor. This is the famous KDIGO heat map. What I want to emphasize here, you see here, the moment you have A2 or A3 proteinuria and you have gradual EGFR decline, there is a almost high risk of cardiovascular mortality and progression to renal failure. Now, microalbuminuria risk factor for CVD, we all know this is the famous Steno hypothesis, which was published in '89, where they says that urine protein not only reflects localized subclinical disease, but generalized vascular endothelial dysfunction. And high sensitive troponin T as a marker of vascular micronecrosis independently predict the transition in albuminuria grade. And microalbuminuria causes fall in adiponectin levels and elevated CRP. So, and there is a significant correlation between degree of proteinuria and CRP level. Proteinuria is also linked with ADMA, which is an inflammatory biomarker which causes endothelial dysfunction. Level of von Willebrand factor is also higher in macroalbuminuria. Macrovascular endothelial dysfunction, which is assessed by flow mediated dilatation, is also impaired in proteinuria. And vascular endothelial growth factor is another interesting potential mechanistic link between proteinuria and endothelial dysfunction. Now, this was the famous PREVENT study, which suggested that urine albumin excretion predicts cardiovascular and non-cardiovascular mortality in general population. You see the hazard ratio as there is a worsening in albuminuria. So albuminuria has been linked to stroke, heart failure, and coronary artery disease, and these are the various famous, studies. I'm not going to get into the details of this. These are also the clinical studies which have reported worse cardiovascular and renal outcome. And diabetes, we all know since mid-80s, there has been accumulating evidence which is linking microalbuminuria with mortality in diabetes, both those with reduced and normal GFR. And overall odds ratio for all-cause mortality in type 2 diabetes with microalbuminuria is 2.4. And there is also a strong association between proteinuria and cardiovascular mortality, well documented both with and without nephropathy. Here you see the cartoon. The moment your kidney starts failing, you have a lot of factors of cytokines or markers which are increased, which cause diabetic nephropathy, atherosclerosis, myocardial infarction, and all this linked to albuminuria. Diabetic kidney disease, we all know it is the prototypical proteinuric renal disease, and clinical diagnosis of DKD is usually made when there is a persistent, moderate, A2 or severe albuminuria or a persistent reduction in eGFR. DKD usually does not cause symptoms at early stage, so guidelines recommended regular screening. So here you can say whenever you have a reduced eGFR or increased ACR in diabetes, if it is type 1 and duration of diabetes is more than 5 years, presence of albuminuria and retinopathy, DKD likely. When you have type 2, if these are present, DKD is likely. When these are not present, think of other causes of kidney disease and think of doing a kidney biopsy if you don't. And there is what we call non-proteinuric phenotype of diabetic kidney disease. It is as high as 50% of type 2 diabetes patients. Declining GFR may be present before in the absence of proteinuria, and progressive loss of GFR and sequential increment of albuminuria may be two different pathways in type 2 DM. This is more relevant in women and in metabolic syndrome. Macrovascular injury and tubular interstitial damage may be two different pathogenic mechanisms. And if you see the incidence in various autopsy series, it can be 23, 19 or 22% respectively. So what are the limitations of microalbuminuria? It is non-specific, low sensitivity and larger variability. And it has been questioned as a surrogate marker because albuminuria does not qualify the Pretens criteria, which in biostats is a criteria to be an ideal surrogate marker. A valid surrogate endpoint must be statistically correlated with the true clinical endpoint and should predict the clinical outcome of interest. A validate surrogate endpoint must fully capture the treatment's aggregate effect on the true clinical endpoint and should account for every major effect of the treatment. This was a systematic meta-analysis which was published in 2019, where they said that proteinuria has been shown, proteinuria has been shown to be independently associated with adverse cardiovascular and renal outcome. The prognostic utility of measuring its changes remains controversial, especially in cardiovascular outcome. And a recent post-hoc analysis of the famous DCCT and EDIC study in type 1 diabetes reported that progression of albuminuria was associated with increased risk of cardiovascular event, but there was a still increase in risk of CV events even when albuminuria remitted. So as a nephrology community or as a physicians, we are still in search of what we call ideal biomarkers. These are the potential candidates which has been looked where, as a nephrologist, we were hardly able to find anything which was more than albuminuria, cystatin C or creatinine. So these are promising molecules which have come up. And this is what you call consortium, which has, there are various molecules and those have been tested on a platform of Luminex, and this is underway to detect diabetic kidney disease or kidney disease at an earlier stage. So what are urinomics? So it is proteomics and metabolomics. One of proteomics is CKD273, which is mass spectrometry based on 273 urinary peptides into a score that has got high accuracy, and it has been developed as a commercial test by Mosaic Diagnostics. Then you have metabolomics. Other candidates are genetic and microRNAs. as I always end my slide with some interesting cases, this case I have presented many a times. This was a 55-year-old male who was resident of Gopalganj, and he was diabetic for 6 years. He presented to us with low-grade fever, generalized weakness, 20 days, urine output, and detected to have deranged renal function. Apart from pallor, nothing much was significant. There was some skin rash. What was interesting to find, again, I want to highlight here is, you can see the proteinuria is trace on dipstick, but it is 8.1 on 24 hours urine protein. So there is a discrepancy between the dipstick and the 24 hours urine protein collection. And he didn't have any diabetic retinopathy. So he had anemia, hypercalcemia, hyperuricemia. So we thought it to be bone marrow examination was done, and we thought it to be came out to be plasma cell proliferative disorder. Electrophoresis M-band was present, and this was the classical cast nephropathy which we saw in the biopsy. Another case, which was 30-year-old male resident of Darbhanga, Bihar. He presented to us with generalized swelling, 3 months, fever and cough with expectoration which he had 3 months back. And he also reported the same, 9 months back. He also presented with decreased urine output and persistent hypotension. And there was various hypotensive recording even before his admission. He was on high-dose vasopressor, massive edema was there, clubbing was there. You can see urine protein was 3+, 24 hours urine protein was 8.1 gram, and he also had a history of ATT twice in back. CT was classically seen cavitatory lesions, but he was not having any major symptoms at this respiratory symptoms at this present time. We wanted to do a kidney biopsy, but we were not able to do so because he was hemodynamically unstable. So we thought of doing, it to be a case. We thought let's try and look whether this patient was having amyloid or not, because since he had a history of tuberculosis and that. So we decided to go for a less invasive method, which was abdominal fat pad. And classically, he had a Congo red stain for amyloid, which was positive. So the amyloid, which was secondary to tuberculosis. And unfortunately, we could not save him. So my take-home message is, albuminuria is an early marker of kidney disease. We are still in search for best way to estimate it. Till the best measured by morning albumin to creatinine ratio. It is considered a precursor to diabetic nephropathy. It has now been linked to adverse cardiovascular outcome and death, independent of other risk factors. Fallacy as a surrogate marker, especially in its prognostication of CV outcome. Trend is more important than the absolute value. High time we begin search for a better reproducible marker of kidney disease. Urine, proteomics, and molecular diagnostics hold promise. Thank you.
Excellent talk, Harshvardhan. Now the house is open for few questions. One question I have in mind, there is 50% cases of diabetic kidney disease have no proteinuria or no albuminuria. So what could be the reason behind it? Why these 50% people did not develop proteinuria or albuminuria? What could be the reason?
Sir, I didn't elaborate on that non-proteinuric phenotype of diabetic kidney disease. Now, those patients, basically, whenever you have a proteinuria, ideally, diabetes, since time immemorial, has been thought as the glomerular disease because it was predominantly affecting the glomerulus. Now, a lot of theories has come that diabetes can also present as a major tubulointerstitial disease because of the vascular injury, because of the other recurrent infections which we have. So if we have predominantly involvement, you may not have the proteinuria as in the beginning, number one. Number two, what we call burnt out glomerular disease, as would happen in any nephrotic illness, once you start having massive proteinuria, and if it starts progressing, you have what you call periglomerular fibrosis and severe tubulointerstitial injury. So gradually your proteinuria, it gradually starts decreasing. So it can be the indicator of burnt out kidney disease, or earlier, if more tubulointerstitial involvement is there, you might not be having.
Please mute.
Actually, Dr. Harshvardhan, excellent talk. I just want to know what is the difference between the diabetic nephropathy and diabetic kidney disease? Both are same, or what is the difference?
No, both are not same. ideally, diabetic kidney disease is, many the diseases which a diabetic patient can have. They can have diabetic glomerular disease, they can have tubulointerstitial disease, they can have renovascular disease, they can have recurrent pyelonephritis, they can have other glomerular disease like membranous nephropathy or focal segmental glomerulosclerosis. So basically, diabetic kidney disease ideally is an umbrella term which is being given to all the kidney disease under the umbrella of diabetes.
Any difference between diabetic kidney disease in type 1 diabetes and type 2 diabetes?
Ideally, in type 1 diabetes, basically you get the classical features of the classical histological renal lesions which you see in diabetes, like the KW lesion, the earliest GBM thickening. But in type 2 diabetes, it is more or less a heterogeneous kind of histopathology which you see because of the multiple risk factors which are associated.
One thing I want to know.
Can we proceed to the next?